Hi, we're going to talk today about ultimate ortho-restorative digital workflow with SureSmile Aligners. I'm Tif Qureshi, I'm chairman of the IAS Academy. I'm a general dentist. I've been involved in cosmetic dentistry for many years, but I do use a lot of aligners for ortho and restorative treatment, which is what we're talking about today. I'm going to start you with this question though. Look at these patients. Are they obvious orthodontic patients? None of these patients ever approach me asking for orthodontics, but how often do you see them? We see them every single day in our practice. These are patients with slightly crowded teeth, multiple incidents of incisal composites fracturing, chipping, perhaps ending up in a crown. What I'm going to say to you today is that actually these patients are screaming out for orthodontics. They need it, but a lot of the time we don't realize they do. So that's fundamentally the basis of what this lecture is going to be about, and how to use SureSmile Aligners to actually make this work for these particular patients. So our goals today are, we're going to begin with understanding the ortho-restorative benefits of aligner treatment. It's not just about cosmetics, and it's actually not just about orthodontics, it's about ortho-restorative benefits as well. We're going to cover the planning protocols of simple occlusion-driven anterior alignment using digital arch evaluation, using your SureSmile digital setup to really make sure things are going where you're planning them to go. I'm going to show you how the digital workflow can result in better planning, communication, and more predictable outcomes. So you make sure the teeth end up in the positions that you planned from the beginning and towards the end without any issues. And this hopefully is going to change the way we approach all patients, not just cosmetic or orthodontic ones. And these are patients sat in your chair every single day. And what you're watching is a small part of a live online SureSmile Aligner course. So my question now is, how can an ortho-restorative approach be so useful in everyday dentistry? Well, it can definitely turn a patient from someone who wanted veneers, and this patient wanted veneers. This is a case I treated many years ago. She wanted veneers, but once we used a little bit of ortho on her with a bit of bleaching, and she got to this point, she suddenly changed her mind and decided to have a little bit of edge bonding done. So you can see what a dramatic difference a little bit of orthodontics can actually make towards a patient in the long term. So she realizes now she doesn't need them. It can also allow the patient to see their teeth improve one step at a time. So again, someone who may have thought they needed more involved work over a period of a little bit of orthodontics, a little bit of tooth straightening, a little bit of bleaching, at this point now decides that she's going to want to have a little bit of edge bonding done to complete her end result. And with a digitally driven ortho-restorative plan, we can make things highly predictable. Now this patient, as you can see, she's got a little bit of upper misalignment. This is actually towards the end of a failed Invisalign case. It just didn't complete. It didn't complete out. And this patient presented to me, and we basically used some SureSmile aligners to align her teeth and get them to the position we wanted to, because we really were after a correct overjet, overbite for proper anterior function. From something simple like that case to something more complex like this, someone who's got obviously a lot of wear going on, a lot of anterior tooth surface loss, I will commonly use SureSmile aligners to actually get the teeth to the right position for function before I then go ahead and restore them, to make sure that the long-term situation for this patient is absolutely predictable. So the next question is, who can carry out this kind of treatment? Now, who is this for? Well, the answer is, with some training and a little bit of mentoring, I believe every single dentist should be able to do this kind of thing. And the simple reason is that actually all teeth often keep moving, okay? Little study tells us something really, really important. This is a study that's been around for a long time. And obviously we know that ortho-treated cases needed retainers, and that's fine. And I think the whole profession accepts that. But what's never really been fully implemented perhaps in the profession is the idea and the knowledge that most crowded teeth will keep moving. So actually that means anterior occlusions can often keep changing over many years. So tooth movement is kind of irrelevant as whether you have ortho or not. If you've got a little bit of mild and moderate crowding, teeth can keep moving. And the typical movements that often occur on patients, again, who have had no ortho, are collapse of arch width, often defined from canine to canine, and you'll see canines collapsing in and incisor teeth moving forwards and backwards and eventually causing collisions with upper teeth. As you can see here with the patient on the left, this lady is now in her 50s. She had lovely straight teeth in her 20s. You can see the mesiopalatal rotation of those upper centrals and that they've been colliding with the lower teeth. And then on the right side, we're seeing actually effectively collapse of arch length from front to back. There's lots of reasons why this happened. It's not wisdom teeth, but fundamentally, the reality is in roughly sort of 85% of patients with lower crowding, you will get increased crowding. And for 65, 75% of patients with some upper crowding, again, it will get worse over time. Now, what this actually means is that if we are not aware of it, if we're not taking repeated photographs or scans, we won't see it. And here's two typical examples of untreated cases. And if you hadn't really taken photographs, would you really have remembered this? So on the left side of the screen, you will see a case with 4 years of movement and wear. And you can imagine what that will be doing to the opposing occlusion. And here on the right side, again, no treatment carried out at all. And watch what happens over 3 years. Now imagine what that is doing to the opposing teeth, and these movements can actually cause the envelope of function to constrict. So if the lower tooth comes forward and the upper teeth haven't moved, the lower teeth through the chewing cycle could start to engage with the upper teeth and who knows, cause chipping, fremitus, or potentially even tooth movement. And I'm going to ask you the question, dental charting as we know it at the moment, does it really record stuff properly? If you only charted and you weren't using photography or scanners, would you notice this change? If you watch the right side of the screen, you'll see a little bit of change in overlap, okay? But particularly if you watch the left, without a photograph or a scan, would a dental chart help you understand or remind you that these particular movements had occurred? Closure of the space, deepening of the bite, chipping of the lower incisors, darkening of the dentine. Would it? It wouldn't at all. Let's face it. I believe that dental charts are useful in some form, but really, with modern day technology, scanners and photography, they should be kind of consigned to the bin. We should be using imagery for our dental charting for us to really be able to see where teeth are going long term. So historically, I would say without simple SLR views or intraoral camera views every 2 or 3 years, how can we tell if things are changing? I often ask a lot of dentists, how often do you take occlusal pictures of patients? And it's rare, I would suggest that every year a patient should have an occlusal picture or some intraoral camera images. And obviously, if you've got a scanner, you could actually get software that will show the teeth moving over time with simple digital monitoring. So you can scan now and then use some software like AuraCheck and then look at the patient again in 2 or 3 years, and you will actually see a visual diagnosis in front of you. It will tell you whether teeth have moved or whether they're worn or chipped, etc., etc. So we've got to think about where the teeth are likely to go. And what you see at the screen at the moment is we have a daughter and a mother. And I would often say to dentists here, which patient is worrying you more? The daughter is she's 24, the mother is late 50s. And obviously the mother looks worse, but actually I'm even more concerned about the daughter because she has a lot of tooth wear for her age. And this is obviously going to get worse over time. The reality is, I would argue, a lot of these patients are not treated early enough, and tooth wear is not discussed, and tooth position is not discussed. And if we have the confidence to be able to use aligners and a little bit of restorative treatment, I know I can stop the daughter ever turning into the position of the mother. That's really the idea of using ortho and restorative dentistry to prevent this sort of downward cascade to effectively a complex treatment, which could even involve some kind of full mouth treatment later on down the line. What's quite fascinating is the more patients you see over time, daughters and mothers, you start to see, or sons and fathers, you start to see changes. And if you look at your patients, older and younger, you can start to sort of predict what's likely to happen. This patient on the left, she's got the classic mesiopalatal rotation of the upper centrals, constricting envelope. You can see her mother on the right has the same thing, but she's lost her anterior guidance years ago and now has a mouthful of crowns on the back teeth. None of those crowns were any crowns I did, incidentally. I've just seen the mother for the first time. So we need to ask where teeth are actually heading long term. Where are they likely to go? Again, here's the occlusal view of the daughter, here's the occlusal view of the mother. And actually you can see it really does tell a story of where things are likely to go with the daughter. So what we should do, and later on through the presentation, I'm going to show you what I did with SureSmile Aligners for the daughter. Here's another example of a daughter and a mother. Again, it's very interesting to look at the inclinations of the teeth, to look at the crowding, and start to predict where the teeth are going to go. And I would actually say the daughter is in a crowding position, slightly worse than the mother is right now. So again, over time, we're likely to see deepening of bite, more wear, perhaps more canine collapse as well over time. So what this really manifests into is we need to think about what happens when teeth move and as they crowd, and how they can start to chip and fail over a period of time. And this is a classic example of a patient who has a constricting envelope due to continued tooth movement. This patient presented to me and she had 6 times over the last few years composites replaced on her upper front teeth. And she told me that none of them lasted any more than about 3 months. So she had the fillings done and then the composites would chip, the fillings done, the composite would chip. And the reason why that's happening is that the upper teeth are continuing to move inwards. They are actually slowly retroclining. The lower crowding is causing the canines to collapse and that front tooth to sort of spill forward. And as a result, this patient ends up with, instead of having a clear envelope of function, the patient ends up with a constricted envelope of function. So the teeth will actually chip, they'll slice slightly and they'll chip and they'll move and they'll basically keep moving and keep slicing off whatever restorations are there. What we really want is to try and get the patient into a position such as this, where we've pushed the upper teeth forward, we've relatively retracted the lower teeth to give enough space for the teeth to move freely. That way the restorations will have a chance to actually survive. So I'll show you what we did with this patient. You can see the end result now. Here's our start point. Here we've used aligners to push the upper teeth forward and align them, and obviously we've aligned the lower teeth. Now we can go ahead and place our edge bonding as well to get our end result. And you'll see this case start. Here's our start position. Here is our end position initially, okay? And the next picture you're gonna see is actually at 3 years. The lower edge bonding was done at 6 months, and none of this composite has broken off at this point. Here's the same patient from the chin up view. Again, no failures at all. Obviously the patient's using a retainer as well. And here's the patient now at 5 years, a little bit of rubbing on the lower teeth. And finally, this restoration on the upper left lateral breaks at 9 years, considering all her restorations are fractured after 3 months. You can see the value of doing orthodontics, placing the teeth into the right position to stop them from breaking and failing over that period of time. This patient now decides to replace all of them. We could have actually just repaired that one, and we took all the old material off, and look at what you see. What you see right there is very similar to the start point. So here we are 9 years later, no veneers needed, no veneers ever placed, and actually we've removed the old material, and now we've gone back to square one and just placed new material on the teeth. And considering the average veneer or crown, I think it's 9 or 10 years, this is a great alternative to that sort of more traditional style of treatment. So if a patient comes into you and starts, saying my front teeth keep chipping, we've got to look further than just restorative treatment. This patient's front teeth again kept chipping, and actually the reason why they're chipping, she again has a very slight mesiopalatal rotation on the upper centrals, and of course the lower crowding spilling forward is causing a constricted envelope between particularly the mesial point of the 2 upper central teeth. Along the canines and the premolars, there's good overjet, but on the central, there is a reducing overjet continually. So by using orthodontics here and aligners, we actually can align the teeth, upright them, and place our edge bonding to get a much better, more predictable result. Placing some veneers on something like this is not solving the underlying problem. If you place veneers on crooked teeth, they're going to keep moving. And therefore, over time, they either might carry on chipping or cause the teeth to move anyway, the opposing teeth to move. And here's the final outcome for this particular patient. Again, could have been treated. Some people would treat this with porcelain veneers or composite veneers, and I would say that's the wrong thing to do. Really, ortho will give the patient what she needs, and then a small amount of bonding can finish it off, and that bonding will survive because the orthodontics is correctly positioned. And when I started doing this sort of treatment quite a few years ago, I just noticed when I started to align and position teeth carefully and correctly, I noticed that cases where we were getting that repeated chipping, it just stopped, and the composite was far more stable. So you'll see this situation occur again and again. And the only way you're going to notice is by following up the patient. So it's super, super important. If you do this sort of treatment, you keep seeing those patients again, and then you'll appreciate the benefits of it. So to summarize that first section, I really strongly believe that moving teeth is not just for orthodontics, it's for restorative dentistry too. Restorative dentists really need to be using a little bit of anterior ortho, or it's quite compromised actually. And even better, with digitally planned ortho, we can get a better occlusion and thus better long-term function. It really does fit together beautifully. So this is where SureSmile comes in, and I've been using SureSmile now for some time, done many cases. There's three main sections with SureSmile. You have SureSmile Aligner, that's what I use, which is fundamentally a clear aligner system where you will send your scans off with some instructions, and it's a full workup done by technicians who you'll discuss with. You'll see your digital setup, you'll agree with it, and then off you'll get your aligners come to you. SureSmile Ortho and SureSmile Advanced are also excellent systems. My recommendation for those is, that's really for much more advanced users or very experienced general dentists or orthodontists. But SureSmile Aligner, as mentioned, is really where the GDP entry point is. And that's what I use most of the time myself. Looking at some of the features with SureSmile, what I would say here is lots of advantages, but really for me, some of the clear things are that the aligners themselves are ultra clear. No doubt that's something to do with the printing technology that's being used. Thus, when they're getting pulled down, you see a lot less striations, and then obviously the ultra clear Essex material. I find actually the facially driven treatment plan very unique. So, as I will show you a little bit later in the presentation, the teeth are positioned with the face. So again, you're unlikely to develop an off angle or something like this. So you're far more likely to get the teeth positioned where you actually want them. And I think it's got many unique digital planning features like that. I do also like the variable trim line, which can actually be really important depending on the case type you're going to do. If you've got a patient with long clinical crowns or a patient with a lot of rotations particularly, you might want a lower trim line or a scallop. A patient with shorter clinical crown height, you may want to have a higher trim line. So it just depends on what you're actually looking for. But the most important thing that I've found is that it's been highly predictable. I mean, literally the cases have probably needed the least amount of refiners of all the systems that I've used over the years. So that's one of the main reasons why I'm using it. A couple of things that are specific with SureSmile as well, and it's important to understand, is that it is scan only. And I think scan only is a very sensible thing because that then automatically reduces a lot of the error. It also means that you can scan obviously beyond the margin, and then that gives you the benefit of to be able to use a variable trim line. If we use impressions only, it would be difficult to use a higher trim line because of the mucocompressive effect and potential soreness. I've never had a patient with SureSmile who has yet developed any soreness on the gum, and that's got to be because of the scanning that we are using as well. Obviously, it's also fully open source, and that's great. So that means it will work with any scanner. You're not tied to a particular system. But obviously, if you've got something like PrimeScan or CEREC, you also have the benefit of the model analysis software and the simulator, all of which are really nice. But the most important thing is, as mentioned, it will work with every system. So how do I plan for multidisciplinary cases with SureSmile? What am I doing? What am I thinking about when I'm going through my case planning? Before anything, the most important thing is to actually do a full ortho assessment. We mustn't just rush straight into a scan, send it off to SureSmile and say, make me some aligners. What we've got to do first is actually mentally put aside what we want to do, look at the patient, come up with a full assessment, list the problems, and give the patient all the options. Even though, the patient may have asked for aligners, we've still got to present the patient with all the other alternatives that are out there. So we need to discuss that with the patient before we decide to go ahead. And a full ortho assessment will look something like this. It really does need to be done at the standard of a specialist, so the patient fundamentally understands the difference between an ideal treatment plan where perhaps everything is being treated to class 1 and all the problems are being corrected, versus a compromise plan where the patient can see what they are not treating versus what they are treating and make themselves an informed choice to decide to go ahead if they want to do that or not. That's essential for consent, and we all need to be doing that. Even if you move one tooth by 1 millimeter, every patient should have an ortho assessment that really looks a little bit like this or is structured a little bit like this. So once we have done that and the patient is keen to go ahead, we can then actually submit our case through SureSmile. Now, one really nice thing is it's very much simple drag and drop, or you can just direct link through PrimeScan or Trios, whichever you have. And basically drag and drop your STL files really is nice and straightforward, nothing difficult about it. So everything goes in quite quickly, and then the next stage is very simply drag and drop the photographs. So we're literally going to just take the images that we need. Now bear in mind, these are only images that SureSmile are asking you for. This will help with the facial positioning as well, but you must obviously take your full set of separate orthodontic images for your ortho assessment as well. Now, what you'll be guided through in the case submission process is something called macros. So you'll see a section saying midline, arch form, class, resolutions, occlusal plane, and instructions. The great thing about this is macros ensure you prescribe treatment accurately. So they are asking the right questions for you to actually be thinking, what do I want? So it's not just a case of, take an impression or a scan, or take a scan and say, make me some straight teeth. You are being prompted to be thinking about what's right for this patient. So one of the first things that you may see is it will say, midline, and do we want to, if the upper midline, for example, is good, well, that's desirable, and we may want to maintain that, and we may want to move the lower to the upper. So just as a general rule, from a midline perspective, an upper midline is a good thing to have. And if the upper or lower are already correct, we should be maintaining those. We shouldn't be deviating those if they're already correct. Also, other tips are that if you have a large lower discrepancy, you may need to accept that. SureSmile definitely can correct that discrepancy, but you need to have a discussion with the patient, because you'll find you may need a lot more aligners to achieve that kind of result. And another little tip that I would give is be very wary of patients who are very midline aware. Not that you can't correct it, but often very midline aware patients sometimes have very high demands as well. And I found that to my own misfortune over the years as well. So the next thing that you'll be asked for is to look at the arch form. So again, if the upper arch form is generally pretty reasonable, it might be you want to adjust the lower to the upper. This is another place where I'll then be thinking about things like landmark teeth. Now, a landmark tooth to me is a tooth that is already aesthetically and functionally positioned correctly. So if I know, for example, that the upper left one distal point of the upper left one on this patient is correct, I want to make sure that that point at the end of treatment, after the staging and setup, is in the same position. I don't want the technicians to have flared that or shoved it forward or brought it back at all. So as mentioned, landmark teeth, if one arch is good, move the other appropriately. We've also then got to consider biotype. So if the patient's got a lot of recession or a poor biotype, we need to be thinking, is it appropriate for me to actually do a little bit of round tripping or to procline the teeth at all? Is it appropriate for that particular patient, and should it be limited if there's recession or a poor biotype as well? You'll next be asked to look at class relationships, and do we want to maintain that molar relationship or that canine relationship? A canine class 1 is really ideal for the best possible overbite overjet. That's really ideal, but not always achievable in every case. The overjet ideally should be about 2 to 3 mil. That's normally what I'm hoping to achieve. 4 millimeters acceptable if you have enough anterior guidance as well. Overbite ideally should be about 30%. And again, it will be one of my instructions that I will aim for. But it might be that you're accounting for restorative treatment as well. And I would say, ideally, at an early stage, if you're a general dentist, try and limit the amount of molar movements that you are going to achieve, because again, molar movements on big ortho cases is a tricky thing to do. It doesn't mean you can't do it, but generally as a rule, particularly in IAS, we would say if there's a lot of molar movement needed, we would suggest for an inexperienced dentist, you're probably better off just referring those cases. So when we're looking at resolutions, we need to consider the Bolton's analysis, and are the upper teeth much wider than they should be relative to the lowers, or are the lowers much wider than they should be relative to the uppers, in which case you may need more IPR on the lower arch compared to the upper. We need a roughly 77.2% ratio for our Bolton's analysis. A thing that I always ask for is to avoid IPR on overlap contacts. That's almost pretty much a standard rule in most of my case requests, because I don't really want to be doing heavy amounts of IPR on, as you can see on the left side of the screen, between the upper left, the upper right central and the upper right lateral. I wouldn't want to do that at the beginning of treatment, so I'd ask for that IPR to be deferred till later through the treatment as well. And this also gives the opportunity, again, to lock down teeth. So as mentioned, probably if we don't want to move the molar teeth or any implant teeth, you would mark those off for not being moved at all. Occlusal plane, again, we're looking at the heights of the teeth. Are we going to flatten the plane out, improve the plane? It also gives you an opportunity to look at the upper incisors. So for example, the case on the left side of the screen, this is quite nice and how the facially driven plan can work. I'm happy with those upper centrals. So therefore, when I'm looking at my landmark teeth, I'm going to use it for vertical positions too. And when I'm looking at my digital setup back from SureSmile, I can see, and as you can see, they've not moved the vertical position of those two centrals because we were happy with them. They've moved the laterals and they moved the canines a little bit, but I haven't changed the centrals because I said, hold those landmark teeth. And as mentioned, you can check that within the facial picture as well. And as mentioned, again, if you have a little limited experience, probably not best to do a lot of large posterior changes as well. And then finally, we've got special instructions. Here you've got the ability to change the trim height. So again, the trim height is important. It depends on the initial movements. If you've got a lot of rotations and if you've got long clinical crown heights, you might want to start with a scallop. It may be that if you've got shorter clinical crown heights and tipping and this sort of thing, you could potentially go for slightly higher finish line as well. That gives you a little bit more retention and rigidity and technically more force through the aligner as well. As mentioned, you probably won't need quite so many attachments as you think. I think SureSmile uses a lot less attachment because you have that ability to actually change the trim line. Often cases that have more scallops usually need more attachments to compensate for the fact that you've then lost that rigidity and retention. Also, this is a good time to perhaps consider overcorrections for difficult movements. It might be that you want to slightly overcorrect teeth, and you can talk to the technicians and ask them to do that for you. And you can also, a nice thing to do is you can also specify when you want the attachments to go on. So if you don't want them all to go on at the beginning to overwhelm the patient, you can easily put in here, please defer attachments to perhaps aligner or stage 3. And finally, tips I would give in this section is if you've got any teeth that have got perhaps a little bit of concern about crowns or RCTs, you can always ask for smaller movements on those particular teeth to be more sympathetic in your movements as well. So let's take a case. This is actually my wife, and we used SureSmile Aligners on her. She had had ortho as a child, arguably not the most successful case, and you'll see her case close up in a second. She had ortho as a child, supposedly comprehensive and some extractions, no long-term retention ever provided to her. Basically, her complaint has been more recently that her bite has been deepening, upper centrals obviously mesiopalatally rotating. She's getting some wear on her lower incisors as well, which you'll be able to see in a second. The laterals are tipping back in a little bit as well. You can see the lower teeth have started to sort of over time shift over a little bit to the right side of the screen, and she's got the edge wear that you commonly see associated with the uppers slicing against those lower teeth. Obviously two missing premolars at the lowers, which makes things a little bit more complex. But ultimately we're looking at obviously a slightly compromised case here. It's not going to be a perfect end result. She isn't looking to treat the molars at all or change anything at the back. She's really fundamentally aiming and trying to improve the upper anterior and lower anterior aesthetics and function as well. So these are minor movements. So one of the questions now is, what do we put in our macros? What's my plan? Well, from the uppers, basically the midline was pretty good. So we were looking to maintain the upper, but we were trying to improve the lower midline. So fundamentally the lowers we wanted to shift over a little bit as well. The arch form, we're reasonably happy with the upper arch, although it does need a little bit of expanding, but the lowers we certainly want to adjust to the upper. And the landmark points for her case were definitely the distals of the upper centrals, because that's the position we want to bring the teeth to. I'm going to bring the mesial point forward and the distal points I'm going to hold, but we'll see that on a slide coming up in a second. Definitely going to maintain her her molars and canines, a little bit of minor canine expansion, but that's it. And I'm aiming for about 2 to 3 millimeters of overjet for her. For her resolutions, we're happy to do a little bit of IPR in the upper arch if needed. And even though we've got gaps in the lower arch, we're not looking to retract those lower canines or distalize them. So I don't mind doing some IPR in that lower arch, fundamentally to try and eliminate the risk of black triangles. If I don't do any IPR in the lower arch and just straighten them up, she will end up with huge black triangles between the lower centrals. So I'm going to ask for my IPR to defer to a little bit later on as well. Occlusal plane, again, fundamentally, we were just looking to undeepen the bite a little bit and to lift her centrals up by about 1.5 mil as well. And basically, there are a few special instructions. Fundamentally, I've mentioned that I'm happy to accept the spaces distal, and she was happy to accept the spaces distal to the canines, and actually to try and fundamentally, we're just trying to improve the midline, but it didn't need to be absolutely perfect as well. So these are the landmark points that we created. I use a piece of software sometimes that just sort of helps me get a plan, and what effectively it's saying is that the green lines are moving to the red lines. So those little X points are going to stay the same pretty much through treatment. And the nice thing is that you can really validate this quite easily using your SureSmile software. And I'm going to show you that with a couple of videos in a second. But you can see how when I superimpose my software over the SureSmile software, they have actually followed my instructions and set things up exactly how we wanted them to go. So when I get my videos back from SureSmile, this is a staging and setup video. One of the first things that I do is I just look at the whole staging, and I just ensure I'm happy with what I'm seeing. And obviously the other thing that I do is I like to show the patient for them to understand the difference between an ideal setup versus the compromised setup that they're about to get. So we're just going through the staging step by step now. Each one of the numbers at the bottom is the aligner number and the step that we're looking at. You're about to see the IPR carried out on the lower teeth at number 15 until we get to our end result as well. So again, we can here at this point, we can look at our various views. We can drag our slider again right back to the beginning. We can actually toggle back and forth as well from beginning to end if you want to, or again press play and you will see the individual movements occurring. So this is just showing in steps. It can be shown in a more smooth animated sequence if you want to on the software, but this way I'm pretty certain that I'm happy with the final outcome. And in the next couple of slides I'm going to show you how I specify individual requirements as well. Again, we are just looking at the general overall lower movements, and are the teeth moving, where are the teeth actually moving to, what's my plan, where are they going to. Again, you can see here, we've been asked to do 0.4 mil of IPR between those teeth, but that will not occur till aligner 15, because I'm only going to do it once those teeth are straight. You can see that's my IPR requirement at aligner 15. And at that point, the teeth will slightly narrow through the IPR, and then the black triangles will close down. So again, there's lots of customization available with SureSmile if you ask for these things to be carried out. So let's now go to how I check my landmark points. So I know where my landmark points are. We know that they are the distal to those upper centrals. So what I'll do is to check with my video. We're going to go to my upper occlusal view. And a really great feature is the grid feature. Now the grid feature basically is each one of those blocks is 1 millimeter. So if you zoom it in, zoom it out, the grid changes as well. And what I will commonly do is I'll basically toggle my start finish point, and you can see the distal points have actually stayed still. And if I press play, which should happen in a second, we'll actually see the teeth move, but they'll basically move forward, but they'll come back to that same position. So we're about to press play now, and this case has a little bit of round tripping, so we've got a little bit of arch moving forward before it comes back. Remember, that's only appropriate if you've got good biotype, which my wife did have, and the final position fundamentally ends up with those distal points, those centrals being the same, with the laterals coming forward, the canine rotating, the other canine coming out a little bit, and the premolar slightly expanding, which is what we wanted. So again, a very good final position, and validated using our digital software. So here's another thing we're going to look at is also the display change and then the overbite change as well. And basically, this is the facially driven plan here, and this is one of the, I think, unique features of SureSmile. So what you can actually do is it will position the 2D image for you. So you can actually toggle forwards and backwards from the start point to the finish point. So here's a start, and now here's a finish. You can see the upper centrals have lifted up as we wished. We can see the eye position relative to the face. We'll also be able to visualize the lower teeth as well. I'm going to basically go to the lip trace in a second. So you'll actually be able to see how the teeth are visible in the whole smile as well. And we'll remove the actual gingival model as well in a second. So lip trace will come on, and again, if we sort of toggle forwards and backwards, you'll see your start finish point. And now we can see the lower teeth as well here. And you'll also be able to fade out the model so that you can basically see that start finish point. So again, here's my start finish point. So again, we can see how the laterals and the centrals relate to the position of the eyes as well. And now we can fade out that model so that the teeth are purely in display to give quite a realistic picture, or this isn't just a simulation, this is actually your digital setup placed in the patient's mouth to actually see where those teeth are going to relate to the lips and the face and the eyes. And as I said, that's for me a really powerful tool, and something that I'm very, very keen to show my patients every time I do a SureSmile case as well. The next thing we're going to do on this particular video is check CEJ to CEJ display change. This is often a quite an important requirement for a lot of patients. They want to show more tooth. So again, using my front-facing grid feature, I can double check how much increase in height we are going to achieve and how much more visibility of tooth we are going to achieve with my SureSmile case. There'll be another patient example later where you see that quite dramatically as well. We can also check our overbite change, again, by just removing the upper model and seeing how much coverage we've now got over those lower teeth. So again, all very useful tools. We're also now going to look at position of guidance, and I'm also going to check the correct enveloper function. So let's have a little look. Firstly here, we're going to check, put the grid on, and we can check our overjet here. So we're going to now check the overjet. And as I toggle my start and finish positions, you can see how the overjet changes and increases. Again, we're not looking at too big an overjet here. We can see the amount of millimeters that we've actually got. And now here's one of my favorite tools. For those of us interested in a correct enveloper function, this is an amazing tool called the clipping frame, where we can actually rotate through the panoramic view of the teeth, almost like through a cross section. You can rotate through that cross section, and you can check all the way along that your overjet and enveloper function technically is going to be correct. So you can see it toggling from the start and finish positions, and you could see how that start position, there was very restricted, right there, very restricted envelope, therefore causing that wear on the lower incisors. Now with the final setup position, we are absolutely bang on. This is an enormously powerful tool, which I use, for me, fundamentally important for my ortho-restorative cases, that I can validate that using SureSmile software. Really good. So we haven't got time to go through all of the individual sections. So what I'm going to do now is just to show you her end result here and show you a couple more cases. So this is where she started. Remember where her landmark points were, and we wanted to bring the laterals out, bring the canine out, and this is where she's ended up finishing. And of course, I've done a little bit of edge bonding. I replaced the edge bonding on her laterals as well, but the lowers are now aligned, but she's got the teeth to where she wanted them to be. You can see the lower teeth as well. We uprighted them pretty well, got to where we needed to get to. Plenty of room for the lower bonding and plenty of room for the upper lateral bonding as well. Uppers have been slightly intruded a little bit, and you can see the difference in her smile, and the fact her smile's a little bit fuller. Her laterals have come forward, and everything is looking definitely more symmetrical. And finally now, I'm going to just show you a quick scan of her retainer. This is actually taken on the first day that we got our prime scan, which we now have. So it's actually only one of the first scans I ever took with it. But basically, her upper retainer was made on a 3D model, obviously created by this prime scan recording, which was super, super easy to use and take, and actually captures images incredibly quickly without having to keep going in and out, in and out, in and out. It's just amazing how the camera works. Anyway, so fundamentally, the way that we need to approach this is that we need to assess, diagnose, and plan our cases carefully. Forgetting about the aligners, we've got to think about what that patient needs. We take our photographs, and yes, then we take our scan. We consent our patients, and if the patient's happy to go ahead with aligners, they understand the difference between ideal versus compromise, they understand the difference and the advantages of fixed ortho versus clear aligners. Once they make that informed choice, we're then absolutely fine to go ahead and submit our case off to SureSmile. I will use the macro system to ensure that I get an accurate prescription, so that I've got the right prompts to be thinking about what I need for that particular case. We'll then get our SureSmile staging and setup back, and then what I will do is I will go through my staging analysis checklist, as you just saw with what I did with my wife, checking the overjet, overbite, CEJ, enveloper function. I go through that on every single case, and if I do that, I know I'm going to get results. So my staging comes back, I look at it. It's very easy to modify that staging, and SureSmile are extremely quick at coming back with you with the modifications. So that's another, big advantage. This is exactly what we did with this case. You can see this patient's sort of start position. We did these upper veneers on him. I did these upper veneers about 10 years ago, actually, and they looked okay, but you can see how they moved over time, and this patient's bite has clearly deepened, teeth had moved, but now we've aligned the teeth and a bit of upper and lower restorative treatment on the edges as well. And you can see the predicted outcome on the lower left side of the screen, and then the actual outcome in front of us, okay? And here's a side view predicted outcome, and now we're gonna see our final outcome with this patient undeepening his bite. Obviously haven't changed those veneers, a little bit of minor bonding on the laterals and on the lower incisors, and that's pretty much it with that particular case. So here's our start point with a deepening bite and undeepen the bite and anterior alignment on this case. And again, perfect SureSmile case, start to finish as well. So how do I make my patients understand that this is actually an important thing to do rather than perhaps just a cosmetic thing? What we really need to do is, as dentists, we need to change our checkup and start to look at some other things that perhaps we don't do traditionally. And I'd suggest we need to be using technology to do so. So, as mentioned, I've been using cameras for years and taking photographs of patients that I haven't treated just as much as the ones that I have. As mentioned, with scanners, we can do the same thing. But if we can actually start looking at patients and start to think about where their teeth are likely to move to, and we understand the concept of little study, I play a game called Tooth Sat Nav with my patients, and we look at pictures of their teeth and I try and explain to them that actually over time, and I say it is over time, it's not quick, the teeth are likely to move. This patient is a 25-year-old patient, and I want her to know and understand that the mesial point of both upper centrals are mesiopalatally rotating. They're moving palatally over time. The distal point of that central obviously is drifting out, and the lateral is obviously drifting in as well. And all that's going to do over time is cause more wear and chipping on those teeth than it should. I mean, it's very, very predictable it's going to happen. Therefore, if we actually treat a case like this, I'm treating it because of that particular area. And I know over time that patient's mesial point of those centrals will become more worn, and you'll see a steeper V shape occur. Someone will try and do bonding on it. Someone may even end up trying to do a veneer or something on it. That's unnecessary. What we actually need to do on this patient is to actually align her teeth, and then it's so much easier to then restore. And that restoration now is not under pressure from continued tooth movement and chipping, etc., etc. So changing your checkup can involve lots of individual bits. I'm only going to talk about a couple here, but fundamentally, as I've mentioned, is we do need a lot more photography of patients we are not going to treat over time. It's absolutely critical. We also should be looking at tooth wear and talking to patients about tooth wear and helping them understand the difference between dentine and enamel. So again, the patients can visualize that tooth wear, and if you take photographs of it now, in 2 years, 3 years time, they can see the difference, or a scan, 2 or 3 years time, they will see the difference. As I said, I will always talk to them about tooth position, help them understand that things are slowly drifting. And I even like my patients to understand what an envelope of function is. And I make a bit of a joke about it, but literally every single day, my hands will revert to this position, and I will explain to a patient what an envelope of function is. I will explain to them if their upper teeth are retroclining, what's happening, or if their lowers are proclining, so that they actually do understand. And I will also give those patients, or do a fremitus test on those patients, because it's often very, very clear and very viscerally clear, and the patients can feel if a tooth is out of position by actually doing a fremitus test, by leaning on the teeth, and it helps those patients understand over time. Looking at the lateral excursions and the anterior guidance excursions is also super important as an interceptive thing. We should never let patients lose their anterior guidance and then start to develop posterior interferences. There's a really easy opportunity to do a bit of ortho, a bit of bonding, to hold the patient in a better position for much longer. Looking at the OVD is also super important at checkups as well. The aperture, the smile, the amount of tooth display, patients can really connect with that, and they can see the difference between what they look like 15, 20 years ago to what they look like now. And also looking at canine width as well, and measuring canine width. Again, much easier to do with scans. And if you look at patients over time, you will see and you'll notice canine width starts to collapse, and what effect that can have on the crowding and the guidance through those patients' lifetimes. So as mentioned, scanning is far more than just impression taking. It's absolutely essential for patient monitoring and communication. It's hugely valuable, as well as photography, for patients to be able to see what is going on. If we don't show them what is going on, how can they understand? And more importantly, how can we actually start to see these changes if we're only using dental charts and no photography? So thinking about those things for the average person who suffers with this sort of worsening problem, an everyday patient, this is someone who, comes into my practice every day, and I'm talking to her about these things going on. This is, the daughter I showed you, mesiopalatally rotating centrals, and you can see what's happened here. History of upper teeth chipping, composite keeps breaking, it's not surviving, it's looking discolored, etc., etc. And what I want this patient to understand is that the overjet is correct on the canines and premolars, but in the central it's reducing. And so I want her to understand that potentially changing tooth position. So she's likely to see that lateral rotate more, but more importantly, those two centrals will rotate in mesially. So she now understands that she's got this constricted envelope of function. When I do a fremetis check and I press on her upper centrals and she bites down, if I press on her canines and she bites down, she doesn't feel a lot. If I press on her centrals and she bites down, she can feel both centrals pulsing slightly. So she's aware that they're not in the right position. We record the dentine and enamel chipping. The most important thing is I'm going to just reassure the patient and say, this is a slow thing. It's not like tooth decay or gum disease, and we can observe this. I never try and panic the patient. Just help them understand so that when they come back next time, they're quite engaged and we're looking at these same things. And ultimately, the offers of treatment are, we can just monitor it. We can put a retainer in or some kind of bite guard in, or we can treat. And what I found in my practice is that having this conversation every day with so many patients, so many of my patients will come back and say, Tif, that tooth that you were talking about, it was wearing, it definitely looks more worn and I can feel it knocking my upper tooth. Do you think we could fix it? And for me, I much prefer that compared to the trying to use smile design to sell treatment to patient, which, I'll be honest with you, that's what I used to do 15, 20 years ago in the sort of whole selling process, which I believe is wrong. I think it's much better for patients to understand the functional benefits they're going to get, and for them to then want that aesthetic treatment and realize, okay, it's aesthetic and functional at the same time. So this was her the position from the occlusal. She understood, and we knew the overjet was correct in that position and incorrect in the centrals. So these little marker points are points that I want to keep exactly the same and maintain through my treatment. So what I'm going to ask SureSmile to do is maintain the canines, only rotate that lateral, and then the centrals to hold the distal points, but basically mesiobuccally rotate those two centrals there. And we'll show you how we validate that using the SureSmile setup software. So that's just the position that came back, which obviously is exactly correct. You'll see in a second the end result. This is where we've ended up. Obviously, there's a retainer on now. And here is the animation. And what I did when the setup comes back again is I'll usually place my grid over, and then I'll very simply, you can see it's a very simple case, not many aligners, but basically I'm then going to just toggle and make sure that the positions, like the midpoint of that lateral, is exactly the same. The tooth is just rotating, that's it. And then the distal points of the central stay relatively the same, but it's more of a mesiobuccal rotation. So we're not dumping those teeth forward and we're maintaining everything else. That gives us really good anterior occlusal control to make sure that we've got the right amount of overjet. And of course you can check that now with your clipping frame to make sure that the overjet and the visuality of the envelope of function is actually correct as well. So that manifests with moving the teeth forward, makes my bonding really, really simple to change. So the teeth kind of like open like a couple of doors technically, and you can see the sort of side view here as well. Think about where these teeth were heading, and let's go back to this patient's mother in a second. So here's our end result, and let's think about where these teeth were actually heading. So this is the patient technically, who knows, in 20, 30 years with more mesiopalatal rotation, more loss of anterior guidance, loads of crowns in the back of teeth. Yes, we don't know that's absolutely going to happen, but you often see a pattern like this emerge. I know because I've improved this patient's upper anterior guidance. She's got an upper retainer, obviously an upper Essex retainer as well. We're already talking about doing edge bonding on those lower incisors. I'm going to probably dull her open slightly. I know if this patient carries on with this sort of dentistry, carries on seeing me, she will never end up in the position that her mum is at. That's really, for me, the goal. And you can see what this does to someone's smile. Even that very subtle amount of tooth movement, not many aligners done, it can massively change someone's appearance. But what makes me even happier is not just the aesthetics, it's knowing that this patient's teeth are functioning much better, which is the way they should be. So, super important if you ever take on this sort of treatment is to have support. If you're going to get into learning how to do aligners, we need to understand what we're doing, how we do it, and actually to perhaps have your hand held. If you've not done aligners before, it's important. And this is what IAS does. This is why we work with Dentsply Sirona. We are, a faculty of general dentists and specialist orthodontists right around the world. And we basically, train people, but then very importantly, mentor them. We don't just train them and let them go. Mentoring is absolutely part of the process so that we can see and check the cases as they progress. This starts with a course, a recorded course, and then a live course as well. They're done online currently and live potentially very soon. And we take the course program together, and then once that is done, and we go through all the basics, then cases are actually submitted through a forum. And basically we will check the cases before they even begin by simple sort of drag and drop. This is all done through an IAS platform. And the whole idea is that we can look at your digital setup, we can look at your assessment, we can look at your x-rays, and we can actually then mentor you through those cases to make sure that you are actually picking the right cases, often saying, no, this might not be suitable at the beginning, but if they are looking good, we'll give you our feedback. We will then actually look at the digital setup for you, and we can help refine those setups to make sure that they are suitable for the patient, maybe changing the timing of the IPR, maybe adjusting some of the setup according to what we see from the photographs as well, to really make sure the cases actually plan out and work correctly as well. If you want to know a little bit more about this whole process and the whole course structure, you can contact any of these members from the SureSmile team or that phone number at the bottom as well. So just to summarize, I think that orthodontics is essential for everyday dentistry, and without it, a lot of anterior dentistry is compromised. I think a lot of patients end up with restorative dentistry on the front teeth when they don't need it, when actually orthodontics was an underlying problem. If I think back to my earlier parts of my career, and I didn't realize about continued tooth movement, when I didn't understand what constricted envelopes of functions could do, I probably ended up crowning teeth that I didn't need to. Once I understood that, I would say in the last 15, 20 years, I've hardly cut any anterior crowns unless I'm actually replacing them. So orthodontics and some restorative is often the answer for a lot of these cases. And that's because teeth continue to move throughout life. And that's something that I think really the whole profession needs to appreciate. And now with scanning and being able to monitor patients over time, we can really follow and track things a lot better. And we're really privileged to be able to do that now compared to what we were having to do sort of 15, 20 years ago. With our aligner planning, I think digital validation of your ortho-restorative requirements are essential. So as mentioned, we can't just take a scan and say, make me some straight teeth. We need to be thinking about why those teeth need to go where they're going, how that's going to affect the anterior function, guidance, and long-term occlusion. What's that going to do for the patient? And SureSmile for me gives me the accuracy and control that I need. And basically, because it's scanned, the software is extremely good, I find it extremely easy to control. I know that my cases are going to plan out exactly where I want them for those ortho-restorative requirements. And again, without lots of excess aligners as well. It's been easily the most predictable system that I've used. And finally, I'm going to say to you, what kind of dentistry do you want to do? Do we want to be constantly recovering people from difficult situations? Or do we want to be interceptive and trying to stop patients going down those more expensive pathways? And let's face it, only a few patients can really afford those expensive pathways of full mouth treatments. A lot more patients can actually afford some simple anterior ortho, some retention, some little bit of bonding. And I know from the patients I've treated, if I do that, those patients will never go down that more heavily destructive pathway, particularly if you are there to look after them as every GDP should be. So finally, we saw these patients at the beginning. How often do we see these patients? Well, like I say, we see them every single day. Maybe it's time we help these people really see what's going on. that it's actually more, it's about more than just tooth decay and gum disease, that there is actually tooth movement going on here as well, and functional changes. And actually, once they understand, they will then choose to have the treatment done through consent and education versus through having to sort of sell anything to them, which in my opinion is definitely the best way of doing dentistry. So I'm going to say thank you very much for your time. I hope you enjoyed this presentation. Thank you for Dentsply Sirona for inviting me to be part of this presentation. Goodbye.